In terms of desire versus arousal, and there was some work you did on how arousal in women, both subjective arousal and physical arousal, there is some concordance. So maybe talk about how is arousal different from desire? Most people don't know what that means, and how that's different, and how that plays a role.
Yeah. So I love how the late Ellen Lahn, who's a dear colleague and mentor in the field, talked about the relationship of desire and arousal. And she explained it as two sides of the same coin, right? So to kind of simplify that even further, desire is the interest in sex, and arousal is the actual physical and emotional experience that happens during sex. And I mean sex in the broadest sense. I don't just mean penis and vagina sex, but it might be other kinds of self-touching or other kinds of sexual activity beyond penis and vagina. So they have a relationship with one another, but they're not exactly the same thing. Now, we and many others have done qualitative work where we've asked women to talk about the differences between desire and arousal. And if you were to ask a random sample of women walking down the street, most of them would have a hard time differentiating desire from arousal, unlike in males, where arousal is very often synonymous with erection, and desire is, well, I want to act on that erection by having sexual activity. So that's the link. And we're measuring those in distinct ways when we do research to try and understand, does a particular treatment impact one or the other or both of them at the same time?
Yeah, and I think a lot of people think arousal is just lubrication in women, and it's much more complex.
It's much more complex, and actually our colleagues who've studied the relationship between lubrication and desire with a little vaginal swab that's inserted often find minimal relationship between extent of actual lubrication, not awareness of lubrication, but actual lubrication and levels of sexual desire. So we need to be really careful. The flip side of that is when we talk to patients who may have been in unwanted, non-consensual sexual situations, and they may have been told, well, you were lubricated, you were wet, therefore that conveyed you wanted it. And the only way to know if a woman wants it is to ask her.
Right.
Don't rely on lubrication, don't rely on anything the body is doing to convey her consent.
Absolutely. Because women lubricate for all sorts of different reasons. And it's a protective mechanism at some points that women will lubricate to protect their bodies. Yeah. Even if they're having an unwanted sexual experience, they still don't want to get hurt. Their body is trying to protect them. And so it is not an indicator of desire, as you mentioned. But it is interesting that when you're in a wanted sexual encounter, that desire and arousal tend to be concordant. Yeah,
exactly. Yeah, and so we and others have a sexual psychophysiology lab in my at my home institution, where you bring women into a private room in a reclining chair, you expose them to erotic films, and then you measure everything you possibly can. You measure her physiological response with a vaginal photoplethysmograph, which is an indicator of, well, it's somewhat of an indicator of physiological arousal. You can measure what her mind is doing by putting something like a little lever affixed to the arm of her chair, and she's moving it back and forth in a way that corresponds with how mentally turned on she is. Then you can give her questionnaires to fill out before and after a film to tap into things like desire. How much did you want to have sex? And we often repeat those measures, at least the self-report ones, 3 days later. So the idea being, when they come into the lab and they have this arousal experience, does it trigger desire when they leave and when they go home? Right? So is the experience of arousal more likely to trigger a motivation?
Let's go into like a little nerdy sort of discussion about what is a vaginal plethysmograph and what does it do?
Yeah. So vaginal photoplethysmograph is a little glass probe that has a photo-emitting diode, basically a little sensor that emits a pulse of light. And that pulse of light, so the woman comes in, she inserts it looks just like a tampon, but it's glass. She inserts it into her own vagina, reclines back in a chair, and there's a long cable that feeds out of that photoplethysmograph probe, and it goes through the wall into the next room, into an amplifier on the other side. And so the idea is that when there's physiological arousal, the amount of light that is scattered off the vaginal wall shifts. So the more arousal, the more the bend in that light. And so that's what's being picked up. So that's why I say it's an indirect measure.
Is that because of blood flow?
Exactly. Yeah.
Yeah. Okay. So the more blood flow you get, the more the light is scattered.
That's exactly right.
Okay. And then the one thing I wonder in all these studies is self-report. So, when there was one study where they looked at how much women self-reported desire, masturbation, and sexual desire for different types of sexual activities. And they put them into 3 different categories. One was they were told that their results would be blinded. Nobody would know who, nobody except for the research team would see the results. One was like you'd be attached to a lie detector test, and one would be that your peers would see it. And they responded very differently. So when they knew that it was just the research team and nobody would know who they were or what they were saying, it was much more synonymous to their male counterparts. But when they knew they were going to a lie detector, and the lie detector similarly, but when they knew their peers were going to see it, they less often talked about their desire and arousal. And then the other thing is that, women tend to want to, not all women, let's be, some people tend to be people pleasers, and they want to give you the answers that you want. Like, oh, this should be causing desire. So I'm going to say it is.
Yeah. Yeah. So, there's a lot going on in that study. One is, let's be honest, when a lot of those studies measure sexual response and sexual function, they do so in an artificial environment, right? So in my environment, although I'm in an academic healthcare center in a department of gynecology, it's still an artificial environment. It's not their home environment. And so there's always that bit of bias, even though they have total privacy in that room, and we reassure them that whatever they respond, there's no impact on us. They're going to get their remuneration regardless of how they respond. And at the same time, a lot of studies are done in undergrad university samples of, average age 19, where there is a higher likelihood of, number one, people doing this for the money or for the course credit. And it's a unique group, right? So these are college kids away from home for the first time, probably more sexual activity, probably more desire. So not the most generalizable sample. So we need to be really careful in our methodologies of how we do these studies. And that's why I think clinically applied research with real patients and real people is ultimately so important and really hard to do at the same time.
Hard to do.
So we need to make sure we fund it.
Yeah. And we know that there are some maybe physiologic differences in how we respond to watching an erotic film versus actual intercourse, right? Like there's different changes in brain hormone findings and things like that. So that's sort of the challenge, I think. Since Masters and Johnson, I'm not sure there's many people who've been doing studies actually watching couples fornicate or
not in North America. Yeah. There's a few sites in Europe where the research ethics boards allow that. It's not going to happen in North America. Well, at least not in Canada and the US. It's not allowed. People can masturbate in the lab.
Yes.
And we know sites in Montreal, Canada, where that's the focus of their research, is having people masturbate in the lab. But even that, there's a lot of effort that has to go in getting ethical approval to get those studies approved.
Yeah. Yeah. That's, would be ideal.
Yeah, wouldn't it?
It would be really.
But, it kind of speaks to this larger societal hang up that well, not you and I, but others still have around sex. And, anytime the NIH or other groups fund sex research, there's always a faction of society that rally together and they protest it. They see the funding of sexuality research as a harm to children. It's a harm to society. And so the fact that, we still have that to this day is a real problem. And it suggests we need better sex education in schools. We need politicians who are savvy in talking about the benefits of talking about sex. We need to get a handle on reducing sexual assault rates, et cetera. It's a collective effort. It's not just, the onus is not just on the scientists and the clinicians to do this.
If you really cared about children, let's lobby, and get better sexual education. Those are the things that we should be doing. And instead we're fighting sexual research. That doesn't even make sense, right?
I couldn't agree more.
And sex is the backbone of society. You cannot reproduce and have more children, which is going to propagate the future of society without sex, right? And you're not going to, if you're unhappy or not enjoying sex, you're less likely to have children, right?
Exactly.
Let's be at the basis. No one can argue with that.
Yep.
Yeah. But we could talk about that all day.
Yes, we could. Hopefully there's some politicians and decision makers listening to this.
Yes, reach out. Please reach out. We will be happy to help you and champion some of this advocacy because it is so important.
Yeah.
So important. Tell me, is there something that we haven't talked about that you feel like people need to know?
I mean, we haven't talked about cross-cultural differences. We haven't talked about what about females who don't identify as women, gender diverse, non-binary, or even trans men. So assigned female at birth who identify as men today. And those are areas where we have far, far less research. We don't actually have a population-based prevalence study on the rates of low desire in trans men versus non-binary females versus cisgender women. So that's an area we need to do more in. And we also know that there are systemic barriers that prevent those groups, but also racialized groups. I do a lot of work in Vancouver with South Asian women, Black women, Indigenous women, really trying to understand what are the barriers preventing them from seeking care. Systemic racism is a huge one. So that's, I think we can't have any topic about sexual health without naming that and acknowledging that. And because those barriers mean that those women are less likely to get help. It might mean that they suffer with their symptoms for far longer, and then it takes a toll on many other aspects of their life. So this is a collective effort, and it's a commitment to overcoming barriers and systemic racism to make sure that these underserved groups are heard.
Yeah. And, we had a really interesting lecture yesterday. So we attended the International Society for the Study of Women's Sexual Health this week together. And there was an interesting lunch talk yesterday about non-Abrahamic religions and how their views on sexuality have formed based on historical underpinnings. And it was really fascinating to see that, I always joke that the Kama Sutra came from India, but yet we don't talk about sex as a South Asian. And it's actually very fascinating. The history is very fascinating, but also it is very difficult for most people to know how to talk to these, particularly women, South Asian women who may have sexual dysfunction, particularly in the older population where they're just or recently immigrated from India or any part of South Asia, because they're like, if you were like, let's why don't you try masturbating? They'd be like, oh no, I just want to be able to have sex without pain. I want to be able to do it so my partner's relatively satisfied, but that's it. Like there's no connotation of pleasure. In terms of sexuality. And I think there's a lot of people working on providing good education to South Asian women in India, which I think is really helpful. But there's a lot of work to be done. And particularly in understanding these populations and their thoughts around sex are very different from the traditional North American views on sex. And so I think that is really, really important. And if you are in a relationship with someone in these situations, it's also important to realize their thoughts about sex are very, very different. It's going to take some time and really dedicated effort to figure that out and figure out ways. And they have to want that to actually improve their sexual function.
Love it. Love that you've named that. So that's more work for all of us to do. And I mean, I'd love to see medical schools and graduate programs dedicating more funding so that those underserved students get into those programs, right? So that we have more Indigenous students, more Black women and others who can then be a champion in their society for these areas of care.
Yes. And there's so many stereotypes about Black women and Hispanic women and, minorities in terms of sex that really need to be changed and we need to teach about it in schools. And the interesting thing, I was talking to Dr. Gordon yesterday about how she became a sex therapist and got this additional education to be a sex therapist in addition to going to medical school. And so the program that she went to at NYU no longer exists. And to her knowledge and my knowledge, there's no specific degree in sex, talking to patients about sex in terms of sex therapy for doctors. And there's no specific like fellowship or anything that you can do. And we don't learn about it in medical school. Like we learn about the physiology of sex. We learn about, and if you're lucky, you may come across someone like myself or Dr. Rachel Rubin or some, a leader in female sexual health who's going to talk about, how to examine the entire vulva appropriately and assess, the clitoris and assess other things. But if you don't, you will go throughout medical school and you will know very, very little about the psychological underpinnings of sex, which are so powerful.
Yeah. Yeah. And that's why having conferences and other opportunities like you and I both enjoyed over the last few days, doing that but also recognizing what are your own blind spots, right? And so if you don't recognize what your own blind spots are and examine your own biases and prejudices, even though none of us want to do that, but we know that all of us have implicit biases. So without doing that kind of introspective work, we're not kind of in a position to make change and be open to learning and doing better and learning from those communities. So yeah, I think as a sex researcher, I think in some domains we've made massive strides. And, thanks to the approval of Viagra in 1998, it really opened the door for this whole field of studying and researching female sexual function. Yet there's other domains where we're still in the dark ages and have a lot more to do. So,
yeah. A lot of work to be done, and hopefully if anyone listening gets inspired, we can continue to work together.